Just want to say hello to everyone in Hobart. Thanks for joining, and hello to everyone in Melbourne. So that was an amazing talk by Derek. I was just listening to what he was saying and this whole multidisciplinary approach to things. I've been practicing as a consultant for over a decade now. And when I first started out, I had this little narrow view of the world and my practice. And when you've got a hammer, everything looks like a nail. That's true in surgery as well. We were trained only steel can heal, knife before wife, that sort of thing. But when you'd say, oh, look, if a patient sees a sleep physician, they're going to get a CPAP machine. If they see a dentist, they might get a mandibular advancement splint. And I had colleagues who would say, look, you've got to stay away from the sleep physicians. You just got to, I can cure sleep apnea, essentially. And which is, it's not true. And as you go along and you have, I guess, cases that fail or don't go well, one example comes to mind when Derek was talking about the narrow palate, a high arch palate, the patient who's got a perfectly straight septum, small turbinates, but incredibly narrow nose. And you've done the surgery, but she's still blocked and her nose is still collapsing. And when I look back now at that with the eyes of more experience, you realize, well, that was the palate, it was really narrow. The expectations were unrealistic. It's the same with children as well. You can tell the parents that we can create more airway, but if you imagine this is a house, you've got a very narrow house where it's like a tent. And you can take furniture out of the house. You don't want to take out too much furniture, otherwise that causes problems, but you're still left with a narrow. But introducing a dentist with an airway experience that you can just rely on, orthodontists for the difficult ones, it just takes a lot of pressure off. And then they come back and some of them don't even need surgery because their palate is expanded. Even in 6 months, it's incredible. And then allergy specialists as well. You can't, I always tell patients, you can't cure allergies with surgery. You can improve delivery of medication, you can create more space, dry things up a little bit, but you live in Melbourne, it's allergy capital. And I was thinking about also prevention, getting kids early. I go to Mildura once a month and I have 4 other colleagues. We go to Mildura and we see a lot of Indigenous patients and we bulk bill them all. And they're some of the most rewarding patients. And they unfortunately have a lot of ear problems. They've got a lot of allergies because all the imported European grasses and that we're allergic to, they're allergic to as well. So they might have big adenoids, big turbinates. And the incidence of chronic ear disease in Aboriginal children, 50% have got a discharging ear. So these kids, they can't hear and they're irritated by the ears. And they've also probably got sleep disorder breathing, so they're not getting enough oxygen. And then there's this negative cycle when all you needed to do was fix their hearing and fix their sleep. So I think of getting in early and taking a preventative approach, and surgery isn't the answer to everything, and neither is dentistry or allergy. It's sort of this combined thing. And over the years, I've built a network of people that I can trust, and Derek has been a game changer for me. I remember when I started working with Derek, he said, Brian, why aren't you sending me any patients? And I thought, well, when did I ever refer a patient to a dentist? Definitely for TMJ. That's how I first got into it. I was looking for a TMJ dentist and I was introduced to a dentist who was interested in airways and expansion. But I thought it was hocus pocus. I thought, well, what are you showing me CT scans for of airways? But that sort of opened my eyes a little bit. And the TMJ is something I have as well. And I have severe sleep apnea. So this is very personal to me. But sort of I learned a lot from Derek. And now I see patients through I guess an airway view as a dental thing that you guys do. And as ENT surgeons, our kudos is we manage the airway. We're the surgeons that you call on if there's an airway problem, you can't breathe. It's not the anaesthetist. We'll call the anaesthetist, they'll call us when there's trouble, but that's a very limited view of airway. We understand the airway, but we understand the dentofacial development. We taught that in our training. No, we weren't taught it, very limited. It was about adenoid facies, long face. Indications for tonsillectomy was sleep apnea and recurrent tonsillitis and a few other things. And the impact of mouth breathing was just a passing note. This is what they'll look like, but it wasn't really, you should do something about it. So this talk is, there's quite a few slides, so I'm going to go over it pretty quickly, but it's just about the snoring child and options from a dental and ENT perspective. And here we go, see this. So I sort of talked about that already. I just want to see if I can get this mouse working now. Children are kind of little adults, but not really quite because they've got different structures. But generally speaking, they've got the same function, the nose. It warms, humidifies, filters air, so it gets to your lungs, and warm and moist, so you're not losing water through respiration. The sinuses, there's lots of theories. What do? Are they airbags? Are they vocal resonance? Are they buoyancy devices? but they're definitely important in the nasal cycle and filtering air. And the turbinates in children, they're like the little sausages I described them, that there are 3 of them on either side, and they're erectile tissue. And you can go on a deep dive into the history of that, and Sigmund Freud had an interest in them as well because they're erectile tissue. But basically, they alternate. They have a cycle of congestion and constriction, and very important for airway function. So you don't want to remove them. The old way of doing surgery was just to chop them off, and you end up with essentially empty nose syndrome. And adenoids in children, they're lymphoid tissue. They've got a role in the immune system. Parents often say they're going to lose their immunity. They essentially know that they're essentially catching the antigens that are inhaled, a bit like a soccer net, and then the body sends the white cells to fight the infection. But there's lots of lymphoid tissue in the body, and maybe in very young babies it would be more important, but generally it's, if they're seeing an ENT surgeon due to large adenoids, they've usually got a good reason to remove them. So then developmental changes in the tongue, that's very important on the impact of breathing, swallowing, oral development, and also the facial structure and the palate, which Derek has covered in detail. And also ENT, we're really covering speech and swallowing as well as smell. And the eustachian tube is an important tube that it's got the same lining as the nose and the lungs. It's a unified airway theory, ciliated columnar epithelium. And so if you've got an allergy in your nose, it's probably going to be affecting your lungs, presenting as asthma, but also can affect your eustachian tube, which can lead to middle ear problems. So you're taking this holistic view. I always look in the kids' ears when I get a referral from a dentist. So impact on snoring, obstructive sleep apnea, sleep disorder breathing. It's really just a spectrum, I think. We don't really worry about simple snoring per se, but it can be a clue for underlying sleep disturbances. And the Epworth sleep score, or that questionnaire, can give you a lot of clues as to, does this patient actually have something more severe if it's affecting their function. And then the multidisciplinary assessment, that's a key thing. Quite a busy slide here, but basically, the question is mouth breathing a problem? It's definitely a problem if you're mouth breathing. You lose the nasal function, which is very important. You're breathing unfiltered air through your mouth, which can lead to, apart from a dry mouth in the mornings, dentition issues. You're drying out your saliva, caries, and also you're losing water overnight, so you're waking up dry. Snoring is worse. Tongue posture, hard palate development, crowding. I think these are all things you guys are pretty much on top of. But it is important to note this ADHD, ASD, which I'll talk about a bit later. So simple snoring is common in children. Sleep disordered breathing sort of covers this spectrum, and OSA, or obstructive sleep apnea, is the most severe form of sleep disordered breathing. And in our training, that was the only one you're really worried about if it was OSA. So simple snoring is really a benign condition. It may be related to nasal congestion, sleep position, temporary obstructions. Sleep disordered breathing, now this is a sort of partial obstruction of the airway, can cause a range of breathing problems during sleep, and it involves disruption in normal breathing pattern. And patients who have sleep disordered breathing, one of the key things, not always, some patients can have severe sleep apnea and have very little symptoms, but generally they start to have a bad night's sleep, and it can affect their behavior. Where OSA in children is the more severe form, where they're actually stopping breathing at nighttime, and they might be seen having gasping, choking, and these apneic episodes. And that is the classical thing, that the child will stop breathing, and no degree of sleep apnea is normal in a child if you're stopping breathing. But it's also the hypopneas, where they may not stop actually breathing, but they're having decreased airflow, hypopneas. And often the worst children with sleep apnea are not the ones that stop breathing, but it's the ones, if you look closely, their ribs are sucking in, they've got tracheal tug, they're really working hard, and they're essentially losing weight even, because it's like they're running a marathon every night just trying to breathe. Some parents are really on top of that, but other parents just have no idea. They don't really pay attention. So snoring, it changes in different age groups. If you're a newborn baby, you're an obligate nasal breather. So if you pinch the nose at a baby, that's pretty much will be fatal. Or choanal atresia, bilateral choanal atresia, is a condition which is very rare, but that presents with essentially a respiratory arrest. So as you get older, you can breathe through your mouth, I think about the age of 6 months, and your normal breathing patterns develop. And children, primary or kindergarten or daycare, they start getting infections, then their tonsils and adenoids can start to enlarge, and there's another peak when they get to school age. And their tonsils and adenoids do eventually regress in most cases, but it may not be till they're 15 to 17. So that crucial development is well beyond that by the time that their adenoids may or may not have regressed. And then in adults, that's obstructive sleep apnea, is much higher prevalence, particularly in Australia. So what are the red flags in a snoring child? I mentioned long pauses in breathing, and I'll often ask, how many seconds did they stop breathing? And if some parents will say 10 or 15 seconds, and if that's the case, if that's true, that's like straight away, I'm thinking this is severe sleep apnea. But even if it's just a few seconds and the parents don't really think too much of it, that's really not normal, a few seconds. And if they have a video recording, then that's really helpful because you can actually, I'd be concerned about that. And then the daytime symptoms are very important as well. And you see these kids who have their tonsils and their adenoids out, they're like a completely different child. Their personalities change from aggressive, crying and always, but more often than you'd think. And I think that can be often a misdiagnosis of other conditions when really all they needed was a good night's sleep. And I've got two young babies, and you see them at the end of the day when they're just about to go to sleep versus the start of the day where they're hugging and kissing and really happy. At the end of the night, they're kind of crying and like very emotional. When you sleep deprived as a baby, you can't emotionally regulate. Home remedies, simple things that can be done. When you lie on your back, everything tends to collapse. So that's your worst position, generally speaking. So on your side or in children, I remember at the Children's Hospital when I was a registrar there, the thing would sleep them on their stomach, so their airways would be maximally open as opposed to on their back. Managing allergies, antihistamines, nasal steroids can help, decongestants for a short time, and then weight management as well. There's a lot of obese kids who have really poor diets, often runs in families, unfortunately, and that is definitely a factor in some patients. There's a lot of skinny patients who've got sleep apnea, but generally speaking, especially in children, you put on weight, you start to snore. So when would you refer to a specialist? Persisting symptoms, so they're not functioning as well, their mood, their behavior. If you're not getting a good night's sleep, your testosterone levels are 50% of what they should be in your blood picture if you're not getting a good night's sleep. And then suspicious signs such as pausing and breathless sleep or restless sleep. So this is an interesting one. I wasn't aware of it until I sort of looked into it. But so if you've got hypoxia, it kind of makes sense. You're going to have altered brain function, and chronic hypoxia leads to ischemia, and you're going to have evidence of learning disabilities essentially. So you're not going to pick things up and your brain is going to be changed. So I think the brain is most plastic around 0 to 4 years of age. So that's the age where you really want to, that's when learning and language is developed. If you implant a child with a cochlear implant after the age of 4, going to be taking a chance. If it's after the age of 8, they'll never really speak normally because their brain's lost that ability to learn. So lower IQ scores, disparities, there's going to be increased gap between these kids who are often already underprivileged. So in conclusion, it's really important to recognize it, address it, early intervention, and work as a team. And I think, just as an aside, when I started seeing dentists who have airway interest, I was like, well, hang on, what do you guys got airway interest for? This is not really your bag, but it really is. You guys are the ones seeing them before anyone else. And it's not true. Get the history, and it's blindingly obvious that your child's got sleep apnea in most of the cases. Yes, there are the borderline ones where I might consider doing oximetry or a level 2 sleep study in a child, but the vast majority is a clinical diagnosis, and you can learn anything if you take an interest in it. So I would say that you guys are actually I'm seeing a shift even the last 5-10 years. Dentists are becoming the experts in airway, and particularly in children and in snoring adults. So I think being aware of your own limitations is very important, but sort of I wouldn't shortchange yourself in that. Undiagnosed and untreated OSA can lead to various health concerns. PSG may be difficult for children with ASD to undergo. So a gold standard in-hospital sleep study is pretty invasive. There's lots of electrodes, and if the child's got autism, it's just not going to happen. And I think you can do this at the lower level sleep studies, oximetry, which are very helpful, but I think these kids are a challenge. And I think that they are the ones to get the history from. And I'll often say to the parents who don't really know, oh, look, I don't know, the kid sleeps in another room. So, well, can you come back and see me in 3 months? But I want you to take some notes, get a diary. Is it worse when they've got a cold? Then they come back and they're sort of, if you ask the right questions, they come back with the right answers. So correlation between autism severity and OSA. So lower autism severity is correlated with more reported OSA symptoms and delayed diagnosis. So we really should just be having a heightened sense of evaluation in children with ASD, particularly those with lower severity and who are heavier, increased BMI. So what's the link between OSA and ADHD? So we know that pediatric OSA has significant implications for neurobehavioral health, growth and development, and affects up to 9.5% of children. ADHD, it's increasingly prevalent, and I don't think it's a diagnosis just for naughty kids. That's really oversimplified, wrong way to look at it. I think it's a neurodevelopmental sort of disorder. But the funny thing is that there's a lot of overlap with ADHD and OSA, and the incidence of OSA in these kids is in the normal population. And if you misdiagnose it, then you're treating the wrong problem. For example, if you're treating a child who you think has ADHD, and I'm not a pediatrician, but if a child has sleep apnea, they just need a good night's sleep. And if you give them dexamphetamine or Ritalin or stimulant, basically, but all they needed was their airway obstruction to be relieved. So if you can treat the OSA, it can have a massive effect on the child needing the treatment or getting the correct diagnosis. And they are overlapping conditions. So tongue tie, definition and prevalence. So this is a bit of a contentious area as well, even in ENT surgeons, in terms of when you wouldn't treat it. And I've certainly anecdotally seen children who, even friends of mine, think of a friend who's GP and his daughter had a tongue tie, and I was like, I think I was a first year ENT resident. I didn't really have a lot of experience. And I said, oh, look, I don't know, it doesn't seem that bad. She had a really bad lisp. She was failure to thrive. Said maybe get an ENT opinion, had a tongue tie release. The child put on weight. Their speech went normal. It was just like, wow, that was totally, it didn't look that severe. And certainly sometimes the children who are very severe, or adults even, they seem to compensate very well. So I think a contentious thing, but certainly it does have impacts, especially if you can't raise the tongue to reach the palate, then that's going to be a cause for a narrow, high arch palate. And it's also going to affect on breastfeeding, potential bullying, sleep disorders, and poor oral hygiene in children. And I think with the breastfeeding thing, one of my kids had tongue tie released by a pediatrician, and you do a bit more because they're very pediatric. I guess they're not surgically focused, so they're not really releasing it as much as, they don't want to cause bleeding, and that is totally understood. But I think dentists understand tongue tie, I think, the best. If I want an opinion on tongue tie that I'm not sure, I'll send it to a dentist who has the interest in tongue tie, involve, someone else. And particularly the second part of the tongue tie is after the surgery. And again, by bitter experience, I remember a child who had a tongue tie release as well as a tonsillectomy. And the child was a teenager, but just refused to eat and refused to swallow, refused to move their tongue. And then it just came back down again. And I realized, well, that was a failure on my part in not anticipating that, but also the child wasn't doing the exercises. So if you don't do the exercises, the surgery is essentially a waste of time. Even the best surgery, I think, is wasted. You can't lick your ice cream. There's lots of things you take for granted. Potential airway obstruction, snoring, treatment options, frenotomy, particularly newborn babies. If it's just a really membranous thing, it can just be broken with your finger, with your thumb, or with the scissors. But the thicker ones will often just require surgical excision, suturing to close the defect. In some cases, even Z-plasty, sort of minor little flaps. And then the speech therapy exercises are so important post-surgery. And there are some controversies in regards to that. I won't go too much into that. So I think a holistic approach, working together, that's the key thing. So funny looking kid, craniofacial syndromes and snoring, OSA, so sort of Down syndrome kids, high risk of sleep apnea. They've got macroglossia, Pierre-Robin's sequence. They've got the retrognathia, needing tracheostomies early on in their age. I guess these are kids that probably a pediatric dentist would see more, but it is important just to realize that the face really determines your breathing. So this is Down syndrome, the sort of things you're seeing apart from the heart defect, short stature, hearing loss, the intellectual disability. They also have these distinct craniofacial anomalies. And these are the kids at Monash. They were doing a study on reducing the size of the tongue, and we do tongue reduction surgery in adults reasonably frequently for the right patients, but we very rarely do it in children. But these were the ones that were having best results. They have really massively open their mouth and their tongue sort of popping out sequence. It's also associated with things like choanal atresia. So these kids are often very sick. I remember when I was at Children's Hospital dealing with a couple of them as a registrar, and wow, these kids got a bad throw of the dice in the genes. Treacher Collins syndrome, another one as well that we see. These are sort of the classic ENT sort of syndromal patients. So let's move on to allergic rhinitis. What is allergic rhinitis? It's an inflammatory condition of the nasal passages triggered by allergens such as pollens, dust mites, and pet dander. Number one would be dust mites. It's the feces of the dust mites. Number two would be grass. Both those things they're really good desensitization treatment options like oral sublingual immunotherapy. Then you've got the other ones such as trees, and I asked if they've got any exposure to mold. any pets. So the symptoms are runny nose, itchy eyes, sneezing, hay fever, nasal congestion, but they'll often have a lot of asthma symptoms as well. So they're a very allergic child, some of these. And I remember that when they did quality of life scores on allergic rhinitis, it's more than severe asthma in terms of your quality of life. I had a flatmate who was a GP, and he said he'd literally moved from the UK to Australia because of his allergic rhinitis. It was so severe. And thought you moved to the wrong state, but for some reason it was okay. But his quality, so whenever he went back to the UK, it was just terrible quality of life. And I lived in the UK for a time, and I found that I was worse in the UK than I was in Melbourne. But I also know GPs who are moving to Queensland because I said, look, we went on a family holiday to Queensland and there was just no allergic rhinitis. So maybe an excuse to move to Queensland, but I think it's definitely got a function on your snoring, your sleep apnea. And if you don't address it, you're going to, I see a lot of kids, and I did this myself, you take out their tonsils and their adenoids and they'd come back and they're still snoring, they're still congested. And then you sort of look closer and you look in their nose and it's like they've got polyps in their nose, but they're just the natural turbinates, which are just so grossly enlarged. And you think, oh, I didn't look at that, did I? It was just they didn't have a runny nose, they didn't have a lot of, and so now with every child, I always look and I do a nasal endoscopy, I'll have a look with the camera. But that's something that's easily missed. When a child's got massive tonsils, you just, oh, it's the tonsils, or they must have big adenoids as well. But the turbinates are really an important part of those for airway. So role of the allergy specialist, well, I wouldn't say that I'm an allergy specialist, but I have an interest in it. And it's very easy to do a blood test. When I worked in the UK, NHS, we do skin prick testing, but a blood test is even easier. You can do it when the child's asleep. And then the treatment options, nasal steroids work very well tolerated. Antihistamines, you can get an antihistamine nasal steroid combination, so you don't have to take a tablet, which has got the side effects of a tablet, which is great. And you can even do immunotherapy, so desensitization treatments. And allergies, pediatric immunologists, adult, they're amazing what they do. You think, oh, look, I think I've got this figured out. And you send them, they go, oh, actually, no, there's this biological agent, this one here. There's all these different, so I think it's very handy to be able to refer. The only problem is that there can be like 6 to 9 month wait to see an allergy specialist in Melbourne. And I think the consultation is pretty prohibitively expensive for a lot of patients. It's crucial. ADHD, they've got a complex relationship, but understand the interplay can lead to improved diagnosis and treatment. So how do I assess the child? History, examination, investigation. I think the history is everything. So I think the history is really important. And then the examination, and the history is hard from kids. They won't give you history. It's really getting it from the parents. Good history, it's really helpful, and taking the time is, I think, is really important. And then investigations. So talking about the background of the child, any associated medical conditions, but then really honing in on their symptoms of airway. So what are they like sleeping? What are they like at nighttime? So are they restless, tossing and turning, sweaty? Do they sleep with their neck hyperextended, grinding their teeth? I was taught that if they're grinding their teeth, it's anxiety. That's the number one cause of anxiety. And I'm sure that is definitely for some kids, but I think a lot of these kids that I get referred to, they're essentially a lot of them are coming with bruxism. I've got sleep apnea. I fractured one of my molars, so I know what it's like when you're not sleeping well. So the history is very important. Asking about underlying allergies, respiratory conditions, previous treatments, often other kids in the family, there's a history of similar conditions. So it often seems to run in families. So asking about the number of infections they get, recurrent tonsillitis, and how often are they getting interrupted with their sleep? They pretty much sleep the whole night, maybe 1 or 2 episodes, or are they constantly waking up? That's a sort of a sagittal view right down the middle. Your eustachian tube runs all the way to the middle ear, ends up there. You can see the opening just there. And that eardrum is red, it's retracted, it's dull. Basically, that tube is blocked because of allergies. And then the air that's in the middle ear is absorbed and it forms like a vacuum, and it's a tympanic membrane, and they get glue ear, hearing loss, behavioral issues. So the adenoids, you can see sit there, and that's the dream adenoid where there's very little, but I can show you the photos. The adenoids are basically, you can't see the eustachian tube for the adenoids. So identifying the underlying issues, so contributing to the nasal obstruction, symptoms, and then evaluating the severity. So when I look at the tonsils, there's a grading system, 1 to 4. There's a similar grading system for the adenoids, which you can tell on X-ray. I think that's really helpful in kids who don't want to let you look in their nose, but the X-rays can sometimes overcall it. Sometimes they can undercall it as well. But certainly, I really find the nasal endoscopy is very helpful in that. And then looking at in the nose, the turbinates, looking for septal deviation, which is surprisingly common in the kids that I get dental referrals for. And I know Derek made a line of underlying severe allergies. And there are special techniques in babies and young children. If you can even just look at them, you can see their mouth breathing. You know, you can put a little mirror looking through their nose, cotton wool to see breathing. If they sound like Darth Vader, that's probably an adenoidal or a turbinate problem. And then assessing the mouth breather, I think we've covered all of this. Hyponasal speech, so that would be sounds like this because they're a hot potato voice. If you've got really big tonsils and adenoids, you lose that normal resonance. And the opposite of that is hyponasal speech, where cleft palate child would be escaping, there'd be air leaking through their nose. But in the patients I see, they tend to be very blocked up. Looking at the jaw position, again, that's something I've learned a lot from Derek and other dentists, and now referring patients to maxillofacial surgeons who I think they really need Bimax advancement to really address their issues, because their tonsils are small, their adenoids aren't really the issue, but look at their mid-face hyperplasia, look at their retrognathia. So then in older children or adults, you've got an internal and that external nasal valve. So the external nasal valve is a nostril. Some people, it's round, it's like ethnic, it's not going to collapse. Whereas other patients, it's like a coin slot. You could put a 5-cent piece down it. And that's the external nasal valve. Whereas the internal nasal valve is a bit further in where the septum meets the turbinate. And in those chronic mouth breathing adults who've got a high narrowed palate, that tent is just like a PP almost thing as opposed to a nice wide structure. Cofenalcaine decongestant, and if that shrinks down, then that's a good sign that medication is going to be a good option. But if you spray their nose and it doesn't change, this is mainly bony hypertrophy of the turbinate. It's made out of bone with a mucosal lining, and if over years and years of allergies, it becomes like a really thickened, hard, bony turbinate, and those patients are not going to do well from medication. They really need surgery. So I think that's a picture of the adenoids. That's grade 1, it's just a little bit, grade 2, grade 3, grade 4. So most of the patients I see are grade 4, grade 3 and grade 4. And the thing about these kids with the big adenoids, you can expand their palate, but it's not really going to change their adenoids because the palate's in front of the adenoids, just basic anatomy. But the turbinates, however, they're in the nose. So if you expand the nose, then that can actually make a big difference. Nasal steroids don't tend to shrink down the adenoids very much, maybe a tiny bit, but very little. So this is me in my rooms doing a nasal endoscopy. But basically, I say to the child, we're going to take it really slowly because you come out with this, you can't see it, but it's like basically a little snake. And only a little bit of it goes in the nose. And the natural reflex is to sort of clench up, which makes it impossible to pass the scope through. But if they just relax, give them some flavored spray, don't mind it at all. I think it's more the psychological fear of what's going to happen. And if I tell them, look, you just tell me to stop, I stop, no worries. And then investigations, blood tests are very helpful. I don't usually do x-rays, I do CT scans or MRIs. And I probably do more sleep studies than most ENT surgeons. And I trained at Monash, and Monash have a Monash protocol for sleep testing kids. So pretty much every child that gets put on the waiting list at Monash with sleep apnea would get an oximetry test, which is just a screening test. And if that shows signs of sleep apnea, they would be done at Monash Children's as opposed to Berwick, Casey. And so by applying that and having gone to Swan Hill and Mildura for the last 8 years, we haven't had any patients that we've operated on there. We published this that had a bad outcome with breathing issues after surgery because we basically played it really safe and did a sleep study. And I think it's very useful. But again, over time, you can do most of it on the history and the examination. And then collaborating with other specialists is really enjoyable, and it just basically better outcomes. Patients, and the reason I got interested in this was because I was sick of seeing TMJ patients who were coming with otalgia, who are upset, depressed, and I couldn't really offer them anything, or I wasn't sure it was TMJ. But if you refer them to someone who really knows TMJ, then it can be life-changing. Something like tinnitus is another condition I think that a lot of ENTs don't want to treat. But if you find the right people who have a passion in tinnitus, then those patients are really well looked after. So treatment recommendations, I think it can be hard to explain something you don't really understand. And I'm not an expert in orthodontics or myofunctional therapy, but I have tried to learn and understand it. And I think if patients can understand the reasons why you're referring to an ENT as well. So that you've got an airway issue. These people do airway issues. And if I send them to, my child's come here about their nose and you're sending me to an orthodontist, they already had their teeth straightened and 7 teeth removed. Why do we need to see another one? But if you explain things, and I think that really makes it a lot easier for your colleagues, basically. I think the oral appliances are great. I've used the mandibular advancement splints. The advantage of sending patients to someone like Derek, who also do airway issues, that if the patient's grinding, as well as mild sleep apnea, moderate sleep apnea, they're going to get looked after from not just the grinding issue, but the actual sleep apnea issue. I use a CPAP machine myself. I don't enjoy using it. They're not easy to be compliant on, but for the right patients, they're like, that's the gold standard. And the maxillofacial surgeons, I went to in a presentation, said, we are the gold standard for treating sleep apnea. It's not the CPAP machine, it's us, because we can do the skeletal advancement. They've got a point. That is pretty radical surgery, but in the right patients, that by advancing everything, that's something that we can't do. So then following up patients, I like to see patients not rush into surgery. So I might say to a patient, finish your palatal expansion, then come back. If you're okay, then maybe you won't need an operation. And maybe half of them are okay, other half they still want to have more room. So you can adjust your treatment plan as you go along. And I think losing weight is a big thing as well. So sleep studies. So I think we're running out of time, but basically you've got basic sleep studies, oximetry, the sort of studies that Derek was talking about. I wouldn't feel too comfortable with those if they're not clinically validated. If they have been, then absolutely, it's better than nothing. But generally I would do oximetry, or I would do a proper sleep study. And it can be very hard in Melbourne doing this, especially since COVID. A lot of the private services stopped existing, but there are a few good sleep services I'm happy to recommend to you. It's pediatric sleep physicians. So basic PS, if I refer a patient to get one in Monash Sleep Clinic, it often get rejected. They say, no, do an oximetry first. So then they have to wait 3 to 6 months to get an oximetry, and then another 3 to 6 months to get a sleep study. So I try and only send the ones that really need it, where it would make a clinical difference. So I talked about hypopneas, where there's decreased airflow, versus OSA, which is defined as a significant decrease in airflow for at least 2 breaths. And you only need about 3 hours sleep to get enough information for a sleep study. It doesn't need to be a full 8 hours. And the AHI is the key thing in terms of number that would quantify what degree of sleep apnea you have. But there's also a lot of patients have got sleep disordered breathing, but they've got a normal AHI. But clinically, they have the same functional issues as the patients with sleep apnea. They're tired, they're brain fog, but they don't have sleep apnea. And I think that my understanding is that we're coming to realize that even though they may not have severe sleep apnea, the functional impact is the same, and they probably should be getting treated despite not having the classical sleep apnea on the score. So I think it's a very useful tool. It's very reassuring when it's normal, but it's not the be all. So yep, home oximetry. I use a service where a colleague of mine, ENT surgeon, set it up. So basically it was set up during COVID, and it was exactly the same oximetry machine and test that's done at Monash Children's, except it's sent out to the patient and they get a little sort of video card, sort of opens up, gives them instructions, and it's pretty compliant with that. And that works really well. It is a bit expensive, but it certainly gets to the result much quicker, and it jumps the queue from going through the Monash system. So the oximetry is limited. If it's positive, it's very useful. If it's negative or inconclusive, then it's not necessarily the child doesn't have sleep apnea. It's more just to pick up the high-risk kids. So then treatment options: lifestyle, dental, orthodontic, and surgical. So lifestyle, things, sleep patterns, their environment, weight, allergies, addressing just their overall health. I think stress is an important thing as well. If a kid's stressed, they're not going to be sleeping well. Allergy testing, I think, is something that should be done more often. And skin prick testing is quite readily available. And blood testing is also available if the child doesn't mind getting a blood test. So then dental treatments, this is where you guys come in, and it's a spectrum of MSE and then maxillofacial surgery or phonetic surgery. And then lifestyle and habit counseling, I think that's really important. I have some patients that come and they just talk to me about how they're trying to lose weight. They're trying to stop smoking. They're trying to exercise more. And you see them every 6 months and actually make progress. And I think have a really good relationship with your patients. I know I do with my dentist. I've been seeing him for years. And I think as ENT surgeons, we're so busy, we don't really see a patient unless there's a specific reason. They don't come in for a checkup. It's either if you haven't fixed them and they're still coming, then that's not the optimal outcome. You just want to see them, fix them, then they don't need to come back, with some exceptions. So ongoing monitoring adjustments, customized treatment plans, early intervention orthodontics, definitely a controversial thing in regards to this, but I think that the parents are increasingly becoming super educated, and they're coming and they've already read the literature, they've already know what they want, and they've already found the people that they want, actually. And I think the ENT community is catching up to that now as well. So medical management, CPAP for severe sleep apnea, oral appliances for the mild to moderate sleep apneas, medication, and underlying medical conditions. Surgical option and new technologies, therapies, well, we've got the nasal surgery, turbinate surgery, adenoidectomy. So that's the sort of upper airway level 1 surgery. And then you've got the sort of throat surgery, tonsillectomy, uvulopalatal pharyngoplasty, tongue-based reduction. Technology, well, the radiofrequency ablation's been around for a long time. That's a very gentle way of shrinking down the turbinates or the tongue base. Inspire therapy, which is the hypoglossal stimulator, hasn't really taken off. They did a big trial at Austin, which was cancelled because of side effects. Nasal surgery. So this is probably a good diagram of what's happening here with the majority of patients. The septum is deviated and it needs to be straightened. But what is missing from this is that you probably take off the lower part of the septum, or you take off the maxillary crest so the septum can actually have room to fit. But that's a very simplified version of what a septal surgery is. Septorhinoplasty is a bit more advanced, where you're sometimes working on the bony anatomy and you're putting in, you can here see the spreader grafts that are put in, and that's what widens and narrow internal nasal valves. So the patients have got really skinny, long faces, narrow noses. If you put a spreader graft in, that can make a huge difference. But the spreader graft, if you make it too thick, they start to look strange. Their nose is like too wide. And so it's only a couple of millimeters of thickness. But if they just widen their palate, you wouldn't even need a spreader graft. So the spreader graft is not as powerful as actually having a normal shaped face. So there are limitations on that. And then with the turbinates in children, we try to be very conservative. The old way of doing it was just burning it, cautery, but that caused a lot of scarring and loss of the cilia function. So by using coblation, you're really submucously sort of causing a shrinkage of that erectile tissue, but maintaining the nice mucosal surface and maintaining their function. Very important not to remove too much. Old way of taking out turbinates was like a scissor. You just chop them out and leave very little behind, and that would lead to empty nose syndrome and a lifetime of misery. So radiofrequency ablation is certainly becoming more popular, particularly in tonsillectomy. So adenoidectomy, it's an evolving technique. Lots of different ways to take them out, from scraping them out to burn, sort of diathermy to coblation, and it's often done with tonsillectomy. I try to do more adenoidectomies than tonsillectomies, because if a child's got really big adenoids, that might be all they need in addition to the turbinates. And tonsillectomy, 1 in 100 chance of bleeding, and it can be life-threatening, especially in a child, 2, 3-year-old child. They lose a little bit of blood. They may not say anything because they're swallowing it. So I think trying to do a minimal approach, but knowing when to take out the tonsils. And then in adults, we'll do this. This is what we call the most painful surgery we do, uvulopalatal pharyngoplasty, taking out the tonsils, trimming the uvula, bringing the palate forward. And that can be a very good operation for snoring and sleep apnea in the right patients. And if they're morbidly obese, it's not going to work. Another type of operation where we're bringing the palate forward, and this is the ENT version of what the maxillofacial surgeons do much more effectively. So this operation, not done so much. And then tongue-based reduction. Those are the tonsils, the tongue, and you're really putting in a device to shrink them down. That's a very aggressive coblation device, which can cause torrential bleeding. So the ones that we would generally use would be much finer and much safer, but they do have risks. And then advancement as well. Some ENT surgeons would do this type of surgery, but generally I think this is a maxillofacial surgeon would be really the best person to manage jaw surgery. I mentioned the hypoglossal stimulator, not really proven. And then MMA, drug-induced sleep nasendoscopy. I do get some patients to have this. I don't do it myself, but I work with ENTs who do. But in the vast majority of cases, you should get a fairly good idea of where the level of obstruction is without having to put the patient to sleep. Right, so just individualizing treatment.